Thank you, Dimitri, for the introduction. Thank you very much, Pina and the organizers, for this invitation. It's indeed a great honor for me to speak in front of you today. I see so many familiar faces. We've been working together and know each other for a long time, so it's really great to be here. The work today, Dimitri mentioned that there's indeed this new module on data science. The work today is a bit what we did before, but I also want to acknowledge Sébastien Courvoisier for the amazing work he's been doing and what will be folded into the new data science section. So this talk is not so much about the data science, more about the machine learning part of things. Let's start by a definition of imaging for precision medicine. And what do we mean by that? So one possible definition for precision medicine is that you want to focus therapies on specific subgroups of patients that are very precisely characterized. So you start from a population of patients. You measure some characteristics, which can be clinical, omics, or imaging. You group these patients together. And then based on this grouping, on this subgrouping, what you do is you choose then your treatment options. For example, surgery or medication. So this is the framework for this whole talk. But when we talk about precision medicine, I'm sure that what comes in your brain is more something like this. This is an example for liver cancer, tumor biology, and you see now that you have two subtypes of liver cancer tumors. You have the proliferative and non-proliferative types. And you see that they're grouped really by characteristics that are about the cells, that are about the expression, the methylation of certain genes, etc. So this is basically the common way that people think about precision medicine. Based on these, then, you have different clinical outcomes and potentially differential therapies. What I want to do today is to, let's say, move a little bit the definition here. And I want to show that imaging does fit very much into precision medicine. And to do that, there's two types of things that you can do for precision medicine with imaging. You can do image-based phenotyping, which is purely imaging. You could do molecular characterization, and you could do a combination of both. On the side of purely image-based phenotyping, you have a lot of techniques these days: radiomics, deep learning, radiological science, so this kind of manual reading of the data, if you want. On the molecular characterization side, you have all the omics, so genomics, transcriptomics, metabolomics that you can have. And I think the very interesting part is what happens at the intersection of these two. So radiogenomics, for example, is a study of the intersection between radiology and the omics profile of some tissue. Imaging genetics, molecular imaging, and image-guided biopsy, these are all examples of the intersection of both, which I think are very interesting. What happens, though, is that where clinical success has been met here is mainly in oncological application. And today, I want to say that there's a lot of room to explore in diseases that are non-oncological and non-Mendelian, right? So we want to explore a little bit. And to do this, I will give you two examples. One in stroke, so this is treatment planning in acute stroke. This one has no omics, just the image-based phenotyping for precision medicine. And the second part will be about subtyping of heart failure patients, which is a large project that we have. So let's get started here with treatment planning in acute stroke. So this is an Inno-Swiss project with the colleagues at Inselspital and, of course, CHUV UNIL. University of Bern and Siemens Healthineers. And you see this name again here, Dr. Patiño Lopez, who's indeed the cornerstone of several groups around the Lausanne area. So how does imaging figure in stroke and in acute stroke? This is the pathway, if we start from left to right, this is the pathway that you follow when a patient arrives at the hospital for acute stroke. First, they're evaluated by the neuro team and the stroke team. And then, just after that, you have the acute imaging. Based on the acute imaging, you then decide on the triage. So the first thing you do is you check the imaging for hemorrhage. If it's hemorrhagic stroke, well, there's not that many options. Basically, give no treatment, stay in the ICU. If you have no hemorrhage, so this is ischemic stroke, then you follow the pathway at the bottom. So you check whether you can give thrombolysis, and this is just an anti-clotting agent, if you want, anticoagulant. And then you also check the imaging again to see if the patient is eligible for thrombectomy. If they are, so this is just mechanical surgery, you remove the blockage, and the patient gets much better. And this has dramatically, over the last 10 years, improved the life of patients. This is really life-saving therapies that has really been enabled in part by imaging. In all of this, you have this little clock, sand clock on the top, which means that time is brain. You need to do this very rapidly. And so you see, again, this pathway, to simplify, is again an example of precision medicine, right? So it's measure, group, and treat. So you see that the imaging is central in here. So let's dig a bit more into how you use imaging to stratify your patients, right? The two parts of an ischemic stroke that you care about are the infarct core, which is tissue that is really severely hypoperfused, probably dead tissue that you cannot recover, and then the penumbra. So you want to compute the volume of the infarct core, VC at the bottom, and the volume of the penumbra. Penumbra is tissue that potentially you can salvage, okay? And then you apply a number of criteria. There's been a number of trials over the years. So this is an example here for kind of a recent trial. You will then use these quantities in several things. You will see the mismatch ratio. So do you have large enough penumbra around the core that you can salvage? Is the volume is indeed something that you can operate? And is the infarct not too large, right? So these criteria, you see these three things. This quantity appears here, this volume. So you see now very clearly, I think, the link with quantitation of these imaging biomarkers. You need to be able to measure this volume of the infarct core, okay? But you see here, there's a unit, 70 milliliters. But milliliters of what? How do you get these milliliters, right? It's not, the patients don't come with built-in quantification. And so here we used, so thanks Jean-Philippe for the introduction to the diffusion imaging. Essentially, the core observation is that the cytotoxic edema leads to cell swelling, which then reduces your diffusion coefficient. You can see on the image here, on the right versus left, so these two. And so essentially, the mean diffusivity lowers, and this you can observe, for example, on the ADC image. And so with this observation, what has happened is a study from 2015 was conducted on 14 patients. And they said, okay, what's the threshold on the ADC value that gives me maximal sensitivity and specificity for the final infarct, right? So they measured with a 30-day flare on the right that you see, and they tried to maximize this overlap, okay? And that's basically the threshold. So now the threshold that you see in many, many clinical studies is 620. But you see, I mean, I hope you're surprised, as I was, that's 14 patients, right? And so really, is that really what we should be doing? So here, what we did here is, Jean-Philippe talked about simulation, that's exactly what we did here. What we wanted to see is how this infarct core volume that is so critical to treating the patient, to orienting the patient, changes if you change the diffusion imaging protocol. So this is, from the top, we have imaging with 20 gradient direction. This is the standard at CHUV. And this was also this idea was also prompted by the fact that we discovered our colleagues in Inselspital in Bern are using 4 directions, so 4 gradient directions. Okay? And so on the top, if you follow, you say you do your threshold at 620, and then you see at the right that you have, this is the red part is the infarct core, if this person is imaged at 20 directions. If this person is imaged at 4 directions, which would happen in the Inselspital, for example, then you have a variety of things that you could do. Because 4 directions, out of which 4 directions, again, are you taking like this, are you taking like this? Like which directions are you taking? This depends a lot on the way the scanner is set up, potentially also the head position. And so this is just a quick simulation. What happens, you can see here, of what happens if you vary these diffusion directions, right? So you can see the infarct core is changing not only the size, but also the location. If you compare these two, what you get is that the Jacquard index, kind of similar to a DICE index, the overlap is around 22%. So this is very, very low agreement, all right? So if you're treated in a hospital that has 20 directions, you will have a certain size of infarct core and the location. If you're treated in another hospital, then you will have a different infarct core. So this is problematic. So we wanted to see how problematic it was. So this is, I have to say also that in the radiology department in CHUV in general, we enjoy fantastic collaboration with our clinical collaborators, including in other departments like neurology. So this, I really want to thank the team of Patrick Michel and the Astral Registry, which is an amazing cohort of stroke patients. So here, what we do, these are results on around 726 patients. The left column is one clinical score, that is the acute score at admission. Middle is after 24 hours, and the right is the 3-month outcome. Okay? And the columns on the left are 4 directions and 20 directions, right? So every time each big column is a different clinical score, and the bottom left is 4 directions, right is 20 directions. The vertical axis shows you the correlation between the infarct volume and the clinical scores. And what's immediately apparent is that you have a huge difference in the correlation between the clinical scores and the infarct size, the infarct volume, depending on the protocol you use. So this is already deeply concerning for, I think, multicentric studies, for example. But what does it change at the individual patient level? So here, again, we discussed internally, and if you apply these guidelines that I showed you before, what happens is this. We have, if you have the 20-direction protocol, out of 100 patients that had thrombectomy, you have 8 that had like an infarct core below this direction, below this volume. If you switch them artificially with this simulation to 4 directions, then these 8 patients would be ineligible for thrombectomy because they don't meet the threshold that the size is small enough. And so this 8 out of 100 is a lot. Like you think that these people could be receiving life-saving therapy, and they're not, and that's a big problem. Okay? And so what is the solution? I'm mainly announcing problems now. Let's talk a little bit about solution. And you can guess, of course, I'm going to say machine learning. And yes, sorry, I have to say machine learning once again maybe saves the day partially. So here's a quick illustration of one thing we did. So we took some data from Inselspital, which is around 300 patients, some open data, 250 patients. And then we trained 2 different models, nothing fancy, just attention unit for those that are interested in this. The protocol at Inselspital is 4 directions resolved. The protocol in ISLES is a multi-vendor, multi-site, 3T, 1.5. It's a hodgepodge of protocols, right? So it's very, very diverse. From this, we apply to a tiny set of CHUV data, so only 16 patients here. And then we get a prediction, okay? And so now what we do is we compare these predictions, and our aim is, okay, if there's good agreement, then okay, maybe we have partially solved the problem, and indeed we're happy to find that it's actually the agreement here. This is a dice coefficient, not the Jacquard, but same ID. Essentially 81% agreement, right? So it seems that compared to what I showed you before, which was around 20, 30%, we can jump just by using deep learning. You can, and having kind of a mixed training protocol, you can do that. And this we didn't do much in terms of harmonization. We did other things to bridge this domain gap between the hospitals. But this is one thing where sometimes deep learning has a bad reputation for overfitting. But if you compare to what's being done in the clinic, you know, with these threshold-based methods, this is a huge improvement. So this is something that we're very happy with. And in fact, we're so happy with it that we want to translate it in the clinic, right? And so what we did is we worked with our colleagues at Siemens to have this as an application that is now installed in hospital IT at CHUV and Inselspital. And so there's a little app store, if you don't know it, called Open Apps. And so the radiologists in the 2 departments, in the 2 hospitals, they can go click, select their application, they can send their cases there, and then they get a little structured report. Right? So this is really something that we're very happy. We're improving. I have to really thank out specifically Sylvia Pistocchi and Vincent Dunet, 2 radiologists that helped us amazingly with this. They corrected the results. So now and this is just this result is not even, this model here, they're reasonably happy with it. It has not even seen CHUV data. Right? So this is also something that makes me very happy that very probably now we can improve it with the corrections that we have. Okay? And so, yeah, so this is the first part for this talk about imaging for precision medicine. Essentially, the bottom line here is that these image-based phenotypes, if you derive them carefully and if you're cautious about the variation in the image, they can be very helpful, and they can indeed orient patients toward better treatment. So this is something we're happy. So now, because this is CIBM, you know, we cannot talk only about the brain. We have to talk about the heart. Of course, Matthias is here, so the heart is great. We like the heart. It's a great organ. And so now we have to talk a little bit about subtyping heart failure patients. So this work is in the context of a Swiss National Science Foundation project led by Ruud van Heswijk. We have also cardiologists in Geneva and Lausanne. Again, fantastic collaboration with our clinical colleagues. I'm very happy. And the work I'm going to show is really the work of Dr. Banu Skobo, a postdoc in my group, as well as Costa Gorgantas, a PhD in my group, that have done tremendous amount of work on this. So heart failure comes in several varieties. Let's talk first about what heart failure is. Essentially, you can simplify it as a failure to pump the blood efficiently. It can come from several reasons. One is that the myocardial walls are too thick, too stiff. The other one is that they're too weak. One quantity we need to know about is EF, ejection fraction. So this is the blood pumped out versus the blood that stays in the left ventricle, roughly speaking, right? So these two quantities. Now, if you combine heart failure and ejection fraction, you can get HFpEF, so very nice disease name, but it's heart failure with ejection fraction that is preserved. And that means that the ejection fraction is above 50%, right? So it's kind of in a normal range. So these people have heart failure, but they're still kind of in a normal range. This is quite high prevalence. It's 1% officially, but it seems to be extremely underdiagnosed, so potentially as high as 12%. The mortality is very bad. It's 15 to 30% at 1 year. And there's few therapeutics. Those that exist have relatively low class of recommendation and low levels of evidence, right? So this seems to be a disease that needs some attention. And so the goal of this project is to try to find subtypes of HFpEF. This was a position paper, the one that you see at the top, saying that, okay, the disease is heterogeneous. Let's find subtypes that are based on some phenotypes, and then let's see if we can treat these subtypes independently, right? So this is, again, exactly going towards precision medicine, not individual patients, but subgroups that are more or less coherent, right? And so as far as 2022 was concerned, this is a nice review as well. There was no multicentric study that had state-of-the-art magnetic resonance imaging, multi-omics, ECG, echo, biochemistry, and clinical. And so, yeah, Ruud has this nice idea to launch this project and to do a lot of integration. So in this project, the goal is really to take imaging, genomics, transcriptomics, metabolomics, and clinical, and then to see, first of all, if we can distinguish controls versus HFpEF, and HFpEF versus HFrEF. HFrEF is reduced ejection fraction, another subtype of HFrEF. But what we really care about is subtypes of HFpEF, and not even subtypes of HFpEF, because you can cluster white noise. We don't care necessarily about clusters. What we care about is clusters that have differentiated survivals. Because if you find clusters with differentiated survivals, that is probably in the signatures of these clusters, you can hopefully find a druggable target for your next clinical trial. Again, this imaging, this precision medicine, you measure things, you group people, and then you treat people. So let's talk about imaging. There's a few omics at the end, but this is mostly about imaging. So how do we derive nice cardiac image-based phenotypes? And if you're in the 1960s, and let's say you want to measure myocardial thickness, this is what you do, right? So this is a myocardial wall thickness transducer. And you might ask, how does it work? Well, it's fine. You know, it's just a stainless steel shaft that is slender, so it's fine. And you just pierce the myocardium, and then you can get your thickness measurements, right? So this is then the time series that you get. So that's one way to get your nice image-based phenotypes. Not really image-based, more like a mechanical force-based. We don't think that we can get the ethics to do that, so instead we do image processing. Of course, this is the CIBM, not necessarily biomechanical engineering, but biomedical imaging. So what we take here as input is a pipeline that does take 4D images. In this case, it works on cine images. You can apply on a number of things. You can do segmentation. Nowadays, this is not necessarily completely routine, but let's say that the bar is very high. So that's the cardiac, the heart is reasonably easy to segment in most contrast, in most sequences. And so this you can adapt a little bit, and then you get your end-diastolic segmentation and systolic segmentation. You do all this image processing things, so slice alignment, etc. You propagate the labels. And then again, you can even sub-segment in this AHA segment, so this American Heart Association segment, if you want to look at sub-parts of the heart. Okay? So this pipeline is really a work of love by Jean Mabanus-Kobo. I will show you some results on UK Biobank, but it's now very scalable, applying to literally tens of thousands of patients in reasonable time. So this, we're very happy with this one. Let me show you what kind of phenotypes you get from this. So this here, we just look now at the thickness. Here we use the ACDC data set, which has several diseases. So here we just show you the normal curve, which is the pink salmon orange curve that you see on top, and that you see that the thickness does change in time, and the bottom one is dilated cardiomyopathy. Okay, so this is just a spatial average of the data, but already you can see that you can go much beyond just the static measure of this thickness, average thickness. You can see really how it changes in time, right? So this is very probably an interesting phenotype to look at. Then you can also do look at strain if you want, spatial temporal. So this is an example here. At the top you have this dilated cardiomyopathic patient. At the bottom you have the normal patient. You see that the motion is much less. The strain also is much different between the two. So this means with this type of approach you can really get down to a lot of detail about the imaging phenotype that you're looking at, and that's a very good target for studying. So this is on ACDC, just 30 patients for healthy controls, 30 DCM patients. What we did is we also applied it on the HeartMagic cohort. So currently we have around 120 patients in HeartMagic. So this is extremely preliminary data that we're showing kind of for the first time here. But just to show you three groups now. On the left you have this thickness curve that we showed you before. And you have the clinical groups. So at the bottom you have the controls, and then HFrEF, and on top HFpEF. And so what you see clearly is that you have this increased thickness throughout the cardiac cycle. And you also see that the contractility dynamics are very different, right, between the healthy groups and the other two groups, right? So this gives us some hope that at least at the group level, we can do this distinction. That's a prerequisite. If you cannot even see difference at the group level, it's probably not likely that you will see difference at the subgroups. And now we're digging a bit more into this with more patients and to see what subgroups we can do. We can also look at the volume index, essentially the left ventricular volume divided by the body surface area. And here you see again this gradation between the groups that is very clear, right? So we see this gradation in these different subtypes of heart failure. Now we need to dig a bit more into seeing into whether that predicts survival, etc. So why do we want to go beyond this ejection fraction? I think this is one case. I want to show some examples from the literature and our own work that shows really this motivation, why you just want to go beyond this static classical ejection fraction to classify patients. So first, this is a tiny study from an abstract, but I found it really interesting. So what they did is they had now 85 heart failure patients, and they tried to look at the survival over a number of days that you see at the bottom. And the top one is what happens when you stratify patients by their ejection fractions, right? So it's just different thresholds on the ejection fraction, reduced, moderately reduced, and preserved ejection fraction at the top. And you see that you don't really have differentiated survival. Instead, at the bottom, what they used here is stroke volume index. It's another measure of cardiac function. And if you do it like this, then you see really clearly differentiated survival, right? So this is a tiny example. And it's not really peer-reviewed, but this is just to illustrate that it is very probable that if you look at the imaging differently, you can find clusters of patients that have differentiated survival. To counteract the first part, this is a much larger study that did find differentiated survival based on ejection fraction alone, right? But the nice thing about the left one is you have very tiny number of patients and you can find still a difference, right? So the effect size on the left is much bigger than on the right, but not to say that ejection fraction is completely unpredictable of survival. Okay. So here, what we're looking at now, we're looking at multiple modalities, but here we wanted to look at fibrosis, right, in heart failure in the data. And why fibrosis? Well, it's linked to the development of heart failure. It's linked also to abnormal systolic function, cardiac remodeling, and stiffness, at least in a rat. And you have nice histological correlations with T1. And it so happens that in HeartMagic, we do have T1 mapping. And so this is something that we're going to look at. But in the meantime, I just want to show you some results on UK Biobank. So this is now with this great pipeline. Now we have no problem processing 30,000 UKB subjects, and that's what we did. Which means that, for example, we can segment the myocardium in T1, we can take the median value, and then we can look for correlations with outcome. Here, the outcome, it's also an outcome, a primary outcome of the study is hospitalization for heart failure. And if you look at this, this is then on, same 29,000 and so patients. If you do just a simple cutoff above versus below median for the T1, then you find differentiated survival. So the effect is small. I'm not going to say it's going to revolutionize patient care, but nevertheless, there is an effect. It is significant. And also UKB is really an observational cohort, et cetera, et cetera. So we have to take this with a grain of salt. But this, again, comforts us in the looking for alternative biomarkers from the imaging. And finally, the final thing I want to share with you, to connect a little bit back to this omics side of things, we also want to look at what's happening in terms of biological pathways, right? So let's stay on fibrosis for now. And here what we do is we use, again, the myocardium T1 median value in these patients. Here we have a few more. We have 32,000 patients. And this is the result of a genome-wide association study, right? So we look at 14 million variants, so mutations in genes, right, over this population. And one by one, we say, okay, is this variant associated with a change in the myocardium T1 value, right? So it's basically a regression, but it's not a regression. It's 14 million regression, so it's really a pain to run. I mean, it runs, but it takes a while. And what we find is actually super interesting. We have 3 hits here. The bar is genome-wide significance, so it's Bonferroni corrected, very harsh, very conservative correction for multiple comparisons. We find 3 hits, CAMK2D, HFE, and SOD2. These genes are extremely interesting. The first one is involved directly in fibrosis and cardiac remodeling. So this is, you might think, duh, but it's not so clear that the imaging phenotype reflects the thing, which, reflects directly the pathway. So this is very nice for us. Also hemochromatosis and DCM, and the last one also has links to DCM, right? So these results are, we have other results. I'm just showing these for now. First, we're very happy with them because it shows that our imaging pipeline and the genetics pipeline is validated at scale, because these hits that we found, they're also found in the previous study. Of course, everybody's using UK Biobank, but the pipeline we have is fairly different, right? So this is nice. It reassures us that we're not, doing garbage correlation. So the next steps with this are, let's have a look at other image-based phenotypes. We already have results. We'll show some other time. And then the ultimate step is to look for drug interactions. So I give you genetics, but what can you do with it, right? So very quickly for this talk, I just did, this is not a drug repurposing study, but it's an interesting thing nevertheless. So SOD2 turns out it's an enzyme that can be activated by mangafodipir. Also for some radiologists, you might know Tesla scan, which was a contrast agent, which was withdrawn in 2012 from the European market, right? And why, if you see the usage for this Tesla scan, you should not use it in severe heart disease, right? So this is an association, for sure. There is a genetic association. This is absolutely not drug repurposing. It's the opposite. But again, it shows us that with this, we can probably find targets that are very closely linked to the mechanisms of disease. So we're also pretty happy with this. So to finish, just some take-home points. First, the imaging for precision medicine is only precise as the imaging allows. I showed you with this example of the gradients. You need to be very careful with your acquisition protocol if you want to do this kind of things. Secondly, I'm now really convinced that machine learning approaches outperform these other classical, threshold-based approach. They're more stable, they're more scalable, they're more reproducible. And spatial-temporal medical imaging needs to be done because now we have all the automation. We don't need to be limited to scalar indices of function. This is done. Now we have all the automation. We can get very nice dynamic markers. And so I think this is a fantastic source of biomarkers for precision medicine. And finally, imaging genetics, I think it's a very good way to offer insights into disease and potential drug targets. Of course, we're not there yet, but all the pipelines are there, so now we can really get going on study. So to conclude, I think that imaging fully belongs to precision medicine, even for non-Mendelian and non-oncological disease. I want to thank the team, the funding, all the collaborators, and you for your attention. Thank you very much.